Αγαπητοί συνάδελφοι, ξεκινάμε το session «Χειρουργική αμφιβληστροειδους προς συζήτηση». Αυτό είναι ένα ανοιχτό session. Μπορεί όλοι οι παρακολουθούντες να υποβάλουν ερωτήσεις, οι οποίες θα απαντηθούν από το πάνελ. Και δίνω το λόγο στον κύριο Πέτρο να παρουσιάσει τους πρώτους ομιλητάς.
Καλησπέρα και από μένα. Θα μιλήσω στα αγγλικά για τους ξένους ομιλητές μας. We would like to welcome you to our session. Hi everybody. Hi Rob, Phil, Thano, Dimitri. We miss you guys. We wish we were here. I have to let you know that there are thousands of people watching this session at the moment. So I'll start with Phil. Please start with your talk. Phil is a consultant with retinal surgeon at Frimley Park in Surrey and honorary research fellow at Morpheus Eye Hospital. Phil.
Hi, thanks very much. Can you hear me okay, and can you see my slides?
Are you in the operating theater?
I am in an operating theatre, yes.
Okay.
But not doing an operation, obviously. No, I was here at work earlier seeing a patient, and rather than be bothered by my kids, I decided to do this from work with a stronger internet connection. Can you hear me clearly, and can you see my slide?
Yes. Yes.
Okay, great. Thanks very much for the invitation.
We cannot see your slides, Phil. You need to share your share screen.
Let's try again. Can you see them now?
That's better. Thanks.
Yeah, apologies for that. So thanks very much again for the invitation. Pity I can't be there in person. Hope everyone's safe and well. Unprecedented times. So scarring success, but only some that can see is the catchy title, but the rather blander title, OCT biomarkers for visual recovery after PVR surgery. We all know PVR is the maladapted, exaggerated wound healing response causing vitreoretinal scarring, the cause of late anatomical failure, with what remains an irritatingly high incidence complicating retinal detachments. We know what the beast looks like. There she is. We also all know that primary success rates are lower than eyes that haven't got PVR. And we also sadly know that visual outcomes remain not as good as we would like them to be. So it's often our, as vitreoretinal surgeons, the bane of our life is once we've overcome our odds and successfully reattached the retina, yet we have a retina that looks normal and a macular OCT scan that looks on the face of it normal. Why then do some people see better than others? Well, in the advent of increasingly more powerful OCT scanning facilities over the last 10 years, with the ability to visualize retinal anatomy at an almost cellular level with higher resolution scans, over the last 10 years, many groups have identified so-called biomarkers or signs in the outer retina and correlated these to visual recovery, at least after retinal detachment surgery, macular off retinal detachment surgery, without PVR in the first instance. Before we move on, it's important that I draw everyone's attention to this slide so that we can agree on the nomenclature, and the majority of the biomarkers are in the outer retina, and so that it's clear what we're going to be talking about later. The outer nuclear layer on a spectralis OCT scan is this layer here. The first outer retinal band of higher reflectivity, the external limiting membrane, is here. This is the ellipsoid zone, formerly known as the IS-OS junction, and this is the outer segments of the photoreceptors. So, as like all good researchers, if we amalgamate what's been done before, we come up with 4 binary variables which have been identified as either present or absent and correlate to visual acuity, namely, firstly, discontinuity of the external limiting membrane, discontinuity of the ellipsoid zone, presence of discrete hyperreflectance abnormalities in the outer nuclear layer, and abnormal hyperreflectancies in the outer segments of the photoreceptors. So 4 binary variables and 4 continuous variables. The first of 2 are included in the automated segmentation software of the Heidelberg OCT machines, and the last two, outer nuclear layer thickness and photoreceptor outer segment thickness, requires manual segmentation. Just before I move on, I'll just give examples of what we mean by the first four binary outcome variables that may or may not be associated with visual recovery. Scans images C and D are higher powered images of A and B for clarity. The white arrow shows discontinuity of the external limiting membrane. The blue arrow here shows abnormal hyperreflectancies in the photoreceptor outer segment layer. The third of the binary biomarkers, these abnormal hyperreflectancies in the outer nuclear layer here, the blue arrow, and this a very clear disruption in the ellipsoid layer, this red arrow here. And I'll try and stick to that color coding throughout. The two that require manual segmentation, the outer nuclear layer thickness is here, and you can see the more difficult to elucidate and segment the photoreceptor outer segment thickness there. So what we did as part of a nested study in the Ozurdex and PVR study, which I reported on last year, was we, as part of our study, we took OCT scans at various time points, but at 6 months, what we wanted to do was to identify eyes that had on the face of it successful anatomical surgery and had what looked like a normal scan, and see whether or not we could correlate these outer retinal changes, these biomarkers, with visual recovery in eyes with PVR. So after excluding eyes that weren't obviously normal, including eyes with CMO, and we can talk later if there's time about whether we should have done that, and eyes that have other reasons for not seeing very well, we were left with 22 eyes that we looked at their OCT scans. And essentially, we performed a linear univariate regression analysis for those four binary outcomes that we've talked about and the four continuous variables. And in the univariate model, we found that outer nuclear changes, those hyperreflective changes in the outer nuclear layer, external limiting membrane disruption, and outer nuclear thickness were significant at a univariate model. But then if we did forward stepwise regression, the only outcome variable that remained significant in the multivariate analysis was disruption of the external limiting membrane. And if we look at the visual outcomes in eyes who had intact external limiting membrane versus those with disruption, we found the visual outcome was significantly better in eyes with external limiting membrane preservation, 618 versus 636. Okay, well, so what does this mean? Well, this suggests that the external limiting membrane integrity does seem critical to visual recovery in eyes with PVR, and it supports what has previously been studied. But one could criticize this study in that this is a heterogeneous group which doesn't exclude or account for the number of operations that patients have had, nor the number of times that the fovea has been off or on, and it's cross-sectional. It was done at 6 months. So perhaps to clean up the data a bit, the most what we might be able to do is follow these eyes longitudinally, and perhaps eyes which presented with primary PVR and had primary success would be a more homogeneous group to look at longitudinally. So in our group of 140 patients, 40 eyes did have primary PVR, of which a half were anatomically successful at one operation. And excluding for eyes that had other ocular comorbidity, we were able to analyze longitudinally 10 eyes. And I just wanted to draw attention to what we found in relation to what we found in the cross-sectional study. But first of all, no surprises when we look at the trend of visual improvement after successful retinal detachment surgery. The biggest improvement in vision of the 10 eyes occurs from baseline to day 10, i.e. once we've reattached the retina, no surprises there. And then again, also from month 3 to month 6, i.e. when we've taken the cataracts and the oil out. But I just wanted to just briefly highlight 3 cases just to confirm and highlight the point that I was making earlier about the OCT biomarkers that seem to correlate with visual recovery. And this composite over 12 months of a patient who had successful surgery for primary PVR shows that at day 10 after initial reattachment, there is no real discernible outer nuclear layer, external limiting membrane or ellipsoid zone. And the top right-hand number here indicates the visual acuity. We start to see some discernibility of the outer retinal structures, but still the visual acuity remains poor. But then as the vision improves, we see here an intact external limiting membrane, but what remains discontinuity of the ellipsoid zone. And we see this following through here as we move to month 6, an intact external limiting membrane with very good vision, outer nuclear hyperreflexencies, which don't seem to have any effect on the vision, and a persistent ellipsoid defect here. Similarly here, another successful primary PVR detachment, no real clarity of the outer retinal band integrity at day 10. Vision starts to improve as we start to see clarity of the external limiting membrane. No real effect on the visual acuity of persistent discontinuity of the ellipsoid zone, and no effect, interestingly, I've included this slide because historically we thought that perhaps persistent subretinal fluid may correlate to poor vision, but we didn't see it in our series. And the vision tends to be preserved and correlates very well with this external limiting membrane continuity. And finally, I've included this case just because it highlights, again, the case very well. Day 10, no real elucidation of outer retinal bands. This is probably a subretinal membrane here. The white arrow showing external limiting membrane reconstitution. The red clarity of the external limiting membrane band here. But then as the vision drops off, we lose clarity of the external limiting membrane. And then as the vision improves again, in the presence of cystoid macular edema and the outer retinal bands look more intact, vision improves. So to summarize, eyes with an intact external limiting membrane see better than those with discontinuity, but they can recover. External limiting membrane integrity does appear to be key to the visual recovery and successful detachment surgery for eyes with PVR. And it does seem to, discontinuity does seem to be independent of ellipsoid zone disruption, and it can occur either the recontinuity or re-establishment of the external limiting membrane continuity either occurs concurrently or independently of the ellipsoid zone restoration. And perhaps this may be a future OCT biomarker, which may provide an objective outcome measure for future trials of novel treatments. I'd just like to acknowledge my co-authors and co-contributors, and thank you very much for your time.
Thank you very much, Phil, for this excellent paper. I have a question. Did you exclude patients with ERM or eyes that had undergone ERM surgery?
Yeah, we did. So you could. So we deliberately tried to, rightly or wrongly, tried to select for eyes that were going to have the best visual outcome and had normal scans. So any eye that had any other potential cause for poor vision was excluded in this study.
Any other question from the panel?
I do have one. Hello, Phil. Hello from Athens.
Hi.
Lovely to see you again. Primary PVR, it seems to be more and more often nowadays. What's your view on that? Do you think that having phacosurgery in terms of refractive surgery purposes may cause an earlier presentation of a retinal detachment with primary PVR?
I haven't got a feel of whether or not refractive surgery creates
intraocular.
Sorry, say that again.
Intraocular. Clear lens exchange procedures.
So I definitely think, and I expect people will agree, that we're seeing more detachments at a younger age for people that are having clear lens extraction. Whether or not I've not personally come across more primary PVR as a result of that, because the nature of patients, I think, that present with detachments following clear lens extractions are usually hyperprimed to it, and so they often present early. I don't know whether people would share my feelings with that, but I have seen a lot more. I've seen a lot more detachments post clear lens extraction at a younger age. So I'm seeing patients in their, late 40s, early 50s presenting with PVD, horseshoe tear-related detachments who have had clear lens extraction privately.
I think it's at least 20 times higher, the risk of retinal detachment in patients who had clear lens extraction.
At a younger age.
Yes, at a younger age.
Definitely. I was just wondering whether you see more primary PVR in these cases.
You might expect it. Yeah, you might expect it because they're younger and therefore may mount more of an immune response. But I haven't seen it, and I wonder whether it's because primary PVR generally is a surrogate marker for the duration of the detachment. In a way, we obviously, if you leave a detachment for long enough, it'll always get PVR. And so, like I said, I think the demographic of patients who have clear lens extractions early tend to present pretty early because they're relatively prime to their symptoms of a retinal detachment. So that may be the reason why we don't see as much, or I don't see as much primary PVR. I don't know whether anyone else is. Are you asking the question because you are seeing more primary PVR in this demographic, or?
I do have a feeling, yes, but I haven't got the numbers yet to be 100% sure on that. So I was wondering whether now that we have loads of VR surgeons from the UK, whether they feel, or from the United States, whether they feel that primary PVR is commoner in patients who are younger and have clear lens exchange procedures.
I agree with Phil. I'm not sure, if it's more common. It's definitely, more common primary retinal detachments without PVR in this age group because of, the clear lens exchanges. But I do agree with Phil. These patients tend to present early on when, they have symptoms. We do see a surge of primary PVR after the beginning of the pandemic. So it seems that my primary PVR cases have, tripled in the last year, just because patients do not want to go into the doctor. So again, that goes back to the duration of the detachment. So we do see a surge right now because of the pandemic.
Phil, can I ask what do you think the causes of those defects in the ellipsoid are? How do they form? Got any theories on that?
Well, I expect their legacy, indicative of the remodeling or the damage that's done when the retina detaches initially. So we know that the outer segments, and we know that they shorten upon detachment, and then they require remodeling. And I think that the degenerative process when a retina detaches is from outer inwards, and then the remodeling process we know is inwards to outwards. And so therefore it makes sense that the ellipsoid zone remodels or reconstitutes after or concurrently with the external limiting membrane. So what are they? I don't know. Are they absent bits of the inner segments of the photoreceptors? Is it true apoptosis? I don't know. It can't be, because otherwise we'd be suggesting that there's a regenerative process going on. So I don't know whether anyone else has any ideas over what it actually is.
Do you see them outside the fovea? Do you see them throughout the retina, or is it just that they're concentrated? Do you see them most prevalently at the fovea?
Well, that's where we're looking for them, I suppose.
Really? You're doing scans the whole way along. Are you seeing them lots of other places too?
Yeah, I don't know. So I mean, you certainly see them extrafoveally, but within the macula. But I've not seen scans, of reattached retina elsewhere, outside the arcade or something. I don't know. That's an interesting point, though.
I mean, we know that the outer segments can regenerate, and so the early CNTF studies showed regeneration of outer segments. Whether that actually happens in vivo, we don't know clearly, but there is some grounds for thinking that if you rip off your retina, you're going to leave a few outer segments stuck in the RPE, and a lot of them will fall off. And I think they do probably. I mean, as long as you haven't completely destroyed your cell body, then there probably is some facility to start rebuilding your outer segment again. I don't know how you prove it. But.
Yeah, it's tricky, isn't it? It's interesting because the the discontinuity of the ELM was historically thought to be irreversible damage to the cell bodies. And I'm not aware of any papers yet that have shown restoration of the ELM longitudinally, which is what we've shown. So yeah, it's interesting. Because it's not, you know, when you think about it, the ELM, it's just the tight junctions at the, you know, it's nothing specific, and anatomically it's nothing very exciting other than the outermost border of where the Muller glial cells extend. But you know, maybe it's more, you know, again, it's indicative of the remodeling process, the critical role that the glial cells have in the remodeling process post reattachment.
Mm-hmm.
I'd like to ask regarding the macular edema. From your work seems not to play a significant prognostic role regarding the final visual acuity. So in this case, you leave it, you try to treat it, and what does not play any significant role long-term towards the visual acuity.
It's interesting because historically we thought that cystoid macular edema was
because we know that the current treatments they are not so effective in these cases, in this macular edema.
Yeah, it's a good question because historically, or so far, the evidence in the literature suggests that eyes that have poorer visual recovery following successful PVR surgery have cystoid macular edema. And in our Ozurdex trial, in the slow-release dexamethasone trial, we reported a significant reduction in cystoid macular edema in the slow-release dexamethasone group, but we didn't see a corresponding improvement in visual acuity in that group. Now, you can read into that in two ways, I suppose. Either we didn't power the study to detect a meaningful difference, or the difference wasn't great enough in that study to be detectable, or cystoid macular edema doesn't have as big a role in visual recovery as we previously thought. And I'm glad you asked the question, because the last longitudinal group of the composite picture that I put up shows an eye that had cystoid macular edema that was present and then got worse and then got better again. And it wasn't the presence of the cystoid macular edema that correlated with the visual acuity, it was the integrity of the external limiting membrane. So perhaps previous studies that have, for example, with retained subretinal fluid, we used to think that that was visually significant. But actually what it probably is that it concurrently existed, or cystoid macular edema concurrently existed with the more critical visual determining presence or absence of the external limiting membrane. So perhaps one should try hard to treat CMO in eyes that has no obvious external limiting membrane continuity, and leave eyes in which the external limiting membrane looks intact. That's a bold statement, but that's probably what I'm going to consider doing, I think.
Okay, thank you.
Thank you. So we're going to move on with our next speaker, Mr. Rob Henderson, who is a consultant adult and pediatric VR surgeon at Great Ormond Street and Moorfields Eye Hospital. So Rob, you're going to talk about the pediatric epiretinal membrane. We cannot hear you, I think.
There we go. Better.
Yeah, that's better.
Okay, good, sorry. Thanks very much. So I am primarily a pediatric vitreoretinal surgeon, though I have an adult practice at Moorfields. So I thought I'd present something that is probably a little rarer for most of you, but certainly has some interesting pointers and some interesting, I'd be interested in your thoughts for those of you that have seen ERMs. These are my disclosures, and I have a particular thanks to my fellow who did a bit of quite a lot of the data collection for this paper. So my interest in pediatric ERMs started quite soon after I was appointed. I inherited this 8-year-old girl who'd been to Great Ormond, the Children's Hospital, with a history of Fusobacterium cerebral abscesses. And at the time she was very sick and had developed papilledema. And so my predecessor noted that when she came back down to clinic, she made a remarkable recovery, but the vision in her right eye was a little reduced. And you can see the OCT at the time. There's some loss of the foveal contour. And over time, he watched her. He was not a VR surgeon. He watched over the next few months a progressive contraction around the macula, the disc, with an extension out temporally, which you can see in this Optos image, and very pronounced thickened epiretinal membrane. And he termed it, as is entirely correct, a combined hamartoma, an acquired combined hamartoma of the retina and RPE. And it got me thinking, what is entity, this so-called combined hamartoma? Because you can see very clearly the mechanism of how it's developed there, with progressive contraction of a very adherent fibrotic posterior hyaloid on the retina. And when we looked at the fluorescein that we did, you can see leakage around that same ring of contraction and extending out temporally, suggesting that the vessels at that particular point were contributing to the hyaloid contraction through maybe leak of inflammatory markers of some description. So I appealed her, as every VR surgeon in the room would probably have done, and indeed her retinal anatomy largely restored. Her vision didn't change much over the next few years, though, so there was clearly, despite reasonable presence of her outer segments, there was still quite a lot of macular thickening. Vision didn't really come up. So I thought I'd pause and just talk a little bit about what combined hamartomas are. They were first described by Don Gass, and he referred to them as an unusual hamartoma of both the pigment epithelium, and he thought they simulated melanomas or maybe RB, but he described a number of different elements to them: the elevated nature of them, the fan-like projections out to the periphery, and this thickening of the posterior hyaloid and epiretinal membrane, and occurring both at the macula, around the disc, and out in the periphery. And we now since know that there are actually quite a lot of associations between combined hamartomas and syndromic conditions, most notably NF1 and NF2, but descriptions with a number of other conditions. Now, if we pause at combined hamartomas and look at pediatric epiretinal membrane, the sort of more conventional membrane that that you and I all know, and they are seen with a variety of conditions that you would expect. So we see that with ROP, we see it with FEVR, we see it with detachment and trauma, as you would definitely expect, and you see it with uveitis, inflammatory eye disease. So nothing that's terribly abnormal there, but what's the relationship between these two entities? So operating on them, well, we operate on epiretinal membranes, and there's certainly good evidence that visual acuity in children will improve quite significantly if you peel them, as you look at these two studies here. And so what I wanted to do is look at the results of the epiretinal membranes and hamartomas that we'd seen at GOSH over the period since I was appointed. So we had 16 patients in total, with a mean age at referral of 7 years, but you can see quite a spread between 3 months and 17 years. And the associations, the majority of them were combined hamartoma, about half of them were combined hamartoma, 2 uveitics. This association with severe systemic infection, as in the first case, was, I think, is probably a novel description. We haven't seen that written anywhere else. And then 2 cases with neurofibromatosis. So I elected to watch 8 of them, and in peds, you know, there's a big discussion to have with the parents trying to take into account the whole child, not just the eye. So we watched 4 because the vision was good, 1 because they were very uveitic, very hot eyes, and were only going to get worse with more surgery. The parents didn't want much done in a couple of cases. So this is a report of the 7 surgical cases, which were associated with uveitis, papilledema, and hamartoma in 4 cases. And you can see there is a statistically significant improvement, albeit in some of them the improvement is not massive, as in the first case. The hamartomas are interesting. 2 of them really did improve quite significantly, with 4 out of the 7 having more than 2 lines of improvement. And one should never forget that, of course, because they're kids and they will start to develop quite entrenched amblyopia quickly. Making sure you patch as well is really important. Really important not to forget. So here are a couple of cases. This is a 2-year-old with very typical features of a combined hamartoma. This thickened preretinal membrane, which on OCT is different to a sort of classic thin little membrane that you'd see on the top with an ERM, and it's really very firmly anchored into the retina. And I think people have, I mean, certainly many colleagues of mine who've seen these have not necessarily thought that these are potentially peelable, but as I'll show you in a video in a couple of slides, they are. You just have to be able to delineate where exactly the separation, how far, how anterior you have to induce a PVD to be able to find the right way to peel it. This I thought was a very instructive case. This is a 5-year-old hamartoma. So in the first case, you can see the hamartoma developing. In this case, you can see the hamartoma present at the macula, and you can see the peripheral RPE change on the left. And then when you peel it, all that RPE change disappears and the retinal anatomy normalizes, and the vision has come up very nicely and is still improving. So this video, I'm hoping that my somewhat paltry broadband is going to stand up, but this video shows just how thick this membrane is. It's sped up, so I'm not this quick a surgeon, but it's a really very adherent, thickened membrane. But if you can identify the more anterior extent of the hyaloid, you can find a cleavage plane, and the whole thing just sort of peels away. And the retina is very distorted underneath it. But you can imagine that with this very adherent hyaloid up to the retina, and the retina then contracting with the hyaloid, and then you've got the interdigitations into the RPE, that pulling on the RPE, you can imagine how this whole thickened hamartoma appears. And so that's my view now, is that actually, for whatever reasons, and we're not clear why they develop all the time, you're getting a profound contraction of the posterior hyaloid in that area, and that's what leads to the appearance. So in summary, epiretinal membranes in children are rare. They do have a wide range of associations, and so it's always worth thinking, consulting with your pediatric colleagues about screening for wider syndromes, including neurofibromatosis, and to think about the natural history, which I think is actually quite similar between ERMs and these combined hamartomas. And I would advocate surgery quite often, unless you think there are very good reasons not to, remembering that the membrane is often extremely adherent, and never forgetting amblyopia. So thanks very much.
Thank you very much, Rob, for the very interesting presentation, and also congratulations on collecting all this information about these patients. We know how difficult it is to get these cases and manage them. I have a question. Did you actually induce the PVD in the 2-month-old child, or?
Yes. It is possible in some children. and we've induced PVDs in ROP cases, rarely. So I always tell the parents I don't know whether or not I'm going to be able to induce a PVD. And there are a couple of nice techniques. Nina Berikal described from Bascom Palmer described a nice technique where she uses the Alcon flex loop, and she goes in the premacular bursa, because that's often actually easier, and she slips the flex loop under the hyaloid there and then induces it towards the disc. And actually, having tried that, that is a very nice way of being able to induce a PVD in smaller children. So whilst I should never try and pretend that getting a PVD in a small child is an easy affair, it isn't. It is occasionally possible. And I think when you've had some inflammation, which can lead to these hamartomas, sometimes there is a bit more of a cleavage plane. Sometimes the PVD comes a bit easier than you think.
Thank you. And also, just the last question from me. Do you have an idea of what happened to the observation group? So, yeah.
Sure. Well, I see most of them still. And so a couple of them have remained stable. The uveitic child has got a lot worse, but has been on absolutely every second, third and fourth line agent, and her uveitis remains poorly controlled. And so the parents her vision in that eye is now very poor. And I think they've decided that actually the chances of being able to rescue vision is probably low, and making the eye worse and probably lose whatever little pressure it's generating is probably quite high. So, and then one child has been lost to follow-up. So, yeah, that a lot of the hamartomas that you watch do remain quite stable. They go through that contractile phase, I suspect, before they get to you, and then they present to you with a squint or with a abnormal reflex that's been picked up by the optometrist, and a lot of them have been there for quite a while, so they're very densely amblyopic. They're trying to undo that is a challenge on top of actually peeling the membrane.
Thank you. Any other question from the panel?
Robert, hello. Lovely to see you again, and congratulations for all this beautiful work that you have showed us today at GOS. I was talking to Petros earlier, and we were thinking of some nice questions and interesting questions, but you somehow covered most aspects. However, I do have a couple of questions. They are extremely difficult cases. Inducing a PVD may be impossible. Do you use 23G, 20G in these cases? Would you go for a higher G?
I go 23 for pretty much everything. It's the best combination of large aperture for being able to capture as many of the hyaloid, as much of the hyaloid in the mouth of the cutter, whilst retaining a smaller enough instrument to be able to get into the small places. And so for ROP surgery, for example, although we really would love to be able to use 25 or 27 because of the size of the instrument, when you're trying to guide your cutter along the side of the lens or between the lens and the pars plicator, having a small instrument would be lovely, but they're just too bendy. You can't really torque the eye. They just distort too much easily. So 23 gauge is where we've stuck, actually.
Definitely. I do think the lens is more forgiving in children, even if you use a 20G. However, I did have with Petros recently a debate on ILM peeling and ERMs. Do you think it has a value in these cases? What are your feelings? I know these cases are not allowed to have a number and comment, but what do you think?
So I'm going to be honest with you. I think if I've managed to get that big posterior plaque off the retina, I'm already internally cheering and thinking, I've done okay here. The thought of restaining, going back in this really swollen retina and trying to peel off ILM in that instance, I think actually if you looked at one of those cases, there probably is residual material there, and there probably is an argument for going back, restaining and seeing if there's more. But I'm normally pretty relieved that I've got away with whatever I've managed to do, and I just want to get out. So can I come back in another 5 years when I've done a few more and give you an answer to that?
Definitely will, and we will be delighted to hear
The
it.
ILM is probably off anyway when you peel
Probably
the
is, yeah.
ERM in these cases.
Yeah.
Phil.
Quick question. So, well, not really a question, more of a couple of statements. Great presentation. Thanks, Rob. What's interesting is throughout my training, was brought up to understand that peeling epiretinal membranes in this context or in this demographic, i.e. combined hematoma of the RP and retinal and the retina is virtually is unsuccessful and difficult for the reasons that you have said initially. But so that's great to know that actually it's possible and doable and that you're getting good results. Because I had this sort of indoctrinated idea that these ERMs are unpeelable by virtue of the fact that they are basically welded into the retina and deeper down. So that's great to know. So I'll be sending them to you if I ever see them. And secondly, I did notice in one of the scans, just to return back to my talk, is that the child tended to lose vision when the external limiting membrane clarity had gone, and when you could see that it had restored, the vision was better again. So that also follows what we found and what is published before. So perhaps that's a marker to look for indications for going in, I suppose, as well. Is it? What's your?
I think that's right. No, I was interested looking because I see these micro defects that you were describing in unrelated other conditions. I mean, I have genetic conditions where I see these little defects and actually have no idea why they have occurred. I think loss of the external limiting membrane is a useful marker for retinal organization in general. So whilst so it is something that I definitely look at and talk to about with the parents when I'm showing them the scans. It's going, I don't know whether or not vision's going to come up, but we'll give it a go, and we're going to patch hard and we're going to see where we get to. So yeah, no, I think there's a lot more we need to understand about OCT anatomy and how it correlates with vision, but I think some of the things that you were saying are absolutely prevalent in other conditions too.
One quick comment. Great talk, Rob. These pediatric ERMs are very reminiscent of these posterior type PVR ERMs we get after retinal detachment surgery. They do behave the same way. They are embedded in the retina. They have contractile properties, and they can drag, the fovea in an ectopic area. Sometimes, when I operate on them, I kind of treat them as diabetic TRDs. I basically segment and delaminate them, and then I just trim them down. But yeah, I agree. The visual prognosis is guarded in these cases. Yeah, great talk.
So it's really interesting that you mentioned the relationship with posterior PVR, because I continue to wonder about residual gel in detachment, and we all know it that when we stain with triamcinolone, if you're someone who stains occasionally with triamcinolone, that you see something left on the surface of the retina. Now what that is, whether it's a sort of coagulum from the triamcinolone or whether there is residual gel, and whether that has a role in PVR formation, and whether the vessels are leaky, a bit like we see in the hamartoma, and that's contributing to some sort of inflammatory cascade. I mean, I make no pretenses to understand PVR, but I do see similarities in the phenotype that you see, I think, between the two conditions. So I agree, absolutely.
Next speaker is going to be Mr. Nikos Georgarakos, adult and pediatric vitreoretinal surgeon, is going to speak about traumatic macular hole in children. Mr. Georgarakos, the ground is yours.
Thank you very much. I'm just waiting for the PowerPoint to see. Right. Thank you very much for the invitation. Thank you very much, Mr. Petru and Professor Brouzas. And I do hope that our audience will find that interesting. Continuing on macular surgery in children, we heard an extremely interesting presentation from Mr. Henderson at GOS, and at least my time at Moorfields working with Eric Ezra, I had the opportunity to work on traumatic the adult population. The difference here is that the majority of the traumatic macular holes do tend to close spontaneously. They do occur mostly in boys, the age between 5 and 17 years old sometimes, and commonly sports-related injuries and related to blunt ocular trauma. The development of the macular hole seems to be. Is that okay, Petros? Yes, yes. Because I think Professor Bruces has stolen my surname, and at the moment, thank you very much. Okay, the names and people given back to owners. No, it's fine. So the development of the macular hole in these traumatic cases happens very fast at the time of the injury, and the mechanism of the injury seems to be related to what happens to the globe at the time of the impact. So you have shortening of the axial length and expansion of the equator, and this seems to be the cause of the changes for the vitreous and the fovea and the macular hole happening at that time. The clinical assessment is very important in these cases because the children usually will present in A&E or to the ophthalmologist with a number of concurrent pathologies. For example, they may have a traumatic uveitis, the posterior pole may be affected by commotion retina, so you need to do an extremely important and thorough clinical assessment. You need also to assess for an RAPD. Visual acuity may be extremely difficult to assess in this population because of the trauma and because of the age, and you need to look for orbital injuries as well. This is the key point here, is that the difference in behavior with the adult population is that they do spontaneously close, and that can happen between 2 weeks or even up to 12 months after the injury, and the majority close between 3 and 6 months. The patients that where we do see the spontaneous closure are younger in age, and and they are young, very young boys. The larger the hole, the slower the rate of closure, and there is an absence of PVD in these cases. So if you do the follow-up, and if you do think that you have some good prognostic indicators on OCT, for example, there is no RPE atrophy and there is no choroidal involvement, then you can proceed with a vitrectomy and C3F8 gas with an ILM peeling. And if they are young, you may need to operate a bit earlier to beat the threat of amblyopia. This is a case of a traumatic hole in a young child, and you see the time of the pre-op OCT and the post-operative OCT. And this is another case which actually got larger a few months later, and this is the post-op. As I said, from my time at Moorfields with Mr. Ezra, we did write up 13 consecutive cases, and to conclude and summarize these findings, they were all males. A vitrectomy, standard ILM pill, and C3F8 gas was used, and 12 of them were closed, and there was one subcapsular cataract developed in 12 months with improvement in visual acuity, as you can see in the logMAR chart. So, to summarize, the role of surgery is important in these cases. especially if they are young and you have the balance of amblyopia versus permanent loss of vision from amblyopia. But there are a few important aspects here. The final visual acuity seems to depend more on the photoreceptor damage and the RPE disruption and the atrophy. The size of the hole from the literature seems to be less important. And there are a few questions whether the long-term functional consequences of a long observation period, the factors for spontaneous close, and if there could be possible management guidelines for macular hole in the pediatric population. Thank you very much.
I like to know what you are doing. You are wait 3 to 6 months until to have a spontaneous closure, and after you proceed to surgery if it is still open, or there are some prognostic indications and you can proceed to surgery earlier.
The classic strategy here is to wait. When you have this child presenting, you don't really want to operate immediately. You have other concurrent comorbidities. You may have commotion, you may have a traumatic uveitis, you may have traumatic mydriasis, you may have a traumatic cataract. You do have to wait for the macula. The majority of them seem to close, and I truly hope that Robert Henderson will agree on that. We always wait approximately 6 months in these cases. And in terms of prognostic indicators, you need to look at the OCT. If you do have a significant RPE atrophy, this is not a good prognostic indicator for visual outcome. However, you do have to try to achieve an anatomical closure. And as we said, amblyopia is a major enemy in the younger ages. I don't know if Robert wants to make a comment here, actually.
Sure, I probably, so first of all, I agree, thank you, lovely talk. I agree that we have to wait. I don't leave it 6 months. I think the probable effects of leaving elevated leaflets and photoreceptors just hanging in the breeze for 6 months is probably detrimental. And while I agree that you probably can leave, and from 3 to 6 months, a proportion of them will close. Certainly in my experience, not all of them do. And so I tend to intervene if they haven't closed by 3 months. I think that that's enough time. 3 months is enough time to see if they'll close spontaneously. If they're not going to do that, I'd probably want to get that hole closed, because we all know, even in adults, intervening quicker in macular hole gets you better vision back in the long term. And so I think the same applies in children. And yes, they have larger functional reserves of photoreceptors. They can afford to lose a few more and still retain good vision. But I departed from the conventional teaching, and I admit, Eric's is very much the conventional approach, which is to wait a significant period of time. But I tend to go in a bit earlier than he does.
One question for you, Robert. If you follow them up, and I don't know, do you follow them up on a monthly basis, 6-week basis, and you do see and you measure the size of the hole, the dimensions, and you have demonstrated some closure. So it does close slowly. Would you still go at 3 months if it hasn't closed but it's smaller, or you would wait?
I mean, there's a conversation, isn't there? And I don't tend to make generalizations, because I think you need to have that chat with the child. And you're right, age is important here. And whether it's their dominant eye or not is important. And, where they are in the school year and how much you're going to disrupt them. And so there are lots of bits of the conversation to have. I think if it's clearly heading in the right direction, and there's I probably don't have as much space in my clinics to be able to follow them up every month, but every couple of months is probably doable. I think if they're definitely getting better, then you can probably afford to watch them for longer than 3 months. But if they're not changing quickly, I'd want to go in.
Okay, lovely. Thank you.
A question for you, Nikos.
Yes,
Yeah, a question actually. Hello, great presentation, Nikos.
Dimitris, hello.
Yeah. Actually, a question for both the pediatric VR surgeons in our company. Do you have any data on refractory macular holes after pars plana vitrectomy for the primary surgery? And if that happens, what do you do for persistent macular holes in the pediatric populations? What strategy do you use? Extensive ILM pill, platelet-rich plasma, grab amniotic membranes. Any thoughts on that?
So my own experience, I have yet to have one fail. That's an N of less than Nick's presenting. So I think I've only had 9 that I've done, and they've all closed. So they do well. And I've never seen one that is the sort of size that you might get in an adult traumatic macular hole, where you get these monsters. So I've never had to do any exciting maneuvers, and I don't do ILM flaps because I don't believe in them. Yeah, they've done very well. So I'm afraid I haven't got an answer for you there.
Yes, Dimitri, I haven't seen one that hasn't closed, but once again, the numbers are very small.
Absolutely.
They definitely behave in a different way than the adult population.
Okay, yeah.
Nick, I have a question, please. Sorry. Great presentation. Thanks. Do you have a feel or any indication, or Rob as well, that the eyes, that the holes that are still open at 3 months that might still close before 6 months? Or is it just that they're getting better clinically? There's nothing to suggest that at 3 months that you can go, well, this may close, or this is unlikely to close, and therefore we need to operate at 3 months. Is there any feel for that, or is the numbers too small and probably wishful thinking?
Is this a question for Robert or for me?
For both.
Well, I don't know why. Nick, you should definitely go and answer this one.
Robert, you go first.
I mean, actually, in truth is, I can't tell you why they are so much better at closing these than adult ones are. I don't know whether there is whether the concussive forces that you find in a traumatic macular hole are somewhat attenuated by the gel, and that often you don't get a PVD, and that somehow that is protective and doesn't seem to lift them quite as much, or maybe helps the leaflets close again because there aren't the fluid currents washing around and keeping it open. I'm not sure what it is that helps them close. Do I know why some close quickly and some don't? I haven't got big enough numbers to really feel, to be honest.
There is a question from the audience. While you monitor a traumatic macular hole, do you see a progressive reduction on the size of the hole?
Sometimes, yeah. Sometimes. So those are the ones that Nick's, talked about, which is the ones that are gently closing and coming down together, and you just go, all right, well, I'm not going to have to go do anything there, and that's fine. The ones that will sit there, much more like the holes that you and I would see in an adult population, those are the ones that I would intervene in, because I don't have any faith that after 3 months, if they're not doing anything, I don't think they're going to suddenly close. Now, I know that the evidence is that some of them do close by 6 months, but I'm afraid I don't sit tight.
Just one comment. The data are so sometimes conflicting in the literature. We published in the past, when I was a resident, a large series of traumatic macular holes, and we saw this spontaneous closure late that Nick was describing in the past, and then another paper was published last year that was saying the opposite thing. The cases are too few to actually, draw a conclusion. And the other problem is that in all these papers, macular holes are not stratified based on the size. You have a small hole, 150 microns, with a lot of hydration at the edges. These things will close. You just give Pred Forte and Ocular and it will close. But if you have larger holes, these are harder to close. The other thing that was mentioned before, how aggressive you have to be for these macular holes, especially the larger ones. I agree with you. I definitely wouldn't be aggressive, especially with autologous retinal transplants and this type of techniques, because then you can open a whole can of worms with endless PVR in the eye, harvesting a piece of retina from the periphery and then putting it in the macula. So definitely not being aggressive with these eyes is a better way to go, in my opinion. Thank you.
Ευχαριστούμε τον κύριο Γεωργαράκο. Επόμενος ομιλητής μας, ο Δημήτρης Τσουρής, χειρουργός ιαλοειδούς αμφιβληστροειδούς από τη Λάρισα. Κύριε Τσουρή, the ground is yours. Μπορείς να ξεκινήσεις.
Καλησπέρα σας και από μένα και ευχαριστώ. Δεν ξέρω, βλέπετε την παρουσίασή μου? Καλησπέρα σας και από μένα. Sorry. Thank you for the kind invitation, both Professor Bruzes and Petros. Something more trivial now and more down to earth following these very exciting presentations from our pediatric colleagues. I'm going to talk about sutures. Sutures, a technique that I found quite useful in dealing with dislocated IOLs or aphakic patients. It all started with a referral for a 70-year-old male who interestingly had bilateral cataract surgery in the past and pseudoexfoliation syndrome. In the left eye, there was a dislocated IOL, and someone decided to exchange that for an anterior chamber IOL without any vitrectomy. So subsequently, the patient developed in the left eye bullous keratopathy and the refractory cystoid macular edema, and ended up with quite poor visual acuity. He was referred for sunset syndrome related to his pseudoexfoliation of his right and only eye, and visual acuity of 6 out of 10. So the plan was to do an ab-externo-scleral suture IOL fixation using Gore-Tex 7.0 loops. The plan was to save and reposition his initial IOL since he enjoyed excellent visual acuity up to the time where the IOL went south. And this is the video, nothing too fancy there, just 7.0 Gore-Tex, 180 degrees apart, creating 2 loops and using 27 gauge docking needles, going through the haptics. And as Professor Bruzets has showed us in the past, one can be quite successful with that and reposition the dislocated IOL as long as we are very careful with our measurements and very exact with the landmarks on the sclera. So in the first surgery, I thought that everything was uneventful. I was quite happy with the final outcome, some anterior vitrectomy to remove Sommer's ring. In the end of the procedure, I realized that the IOL was slightly eccentric, but I thought I would give it a few days and see what happens. However, the next day, the visual acuity did not improve that much. The patient was quite unhappy, and I had the slightly eccentric but tilted IOL. So I thought that I need something, if it would be possible, instead of removing the IOL and exchanging it for either a Carlevale lens or an iris glow or whatever. I thought I'd give it a try and find something that could give me a posterior push, a posterior support, like a scaffold or to the optic, so that if I managed to make the lens less tilted, maybe I could save the patient's vision and another surgery. So the plan was to take him back in surgery, do an anterior synecholysis, because by the time I was following him up. He developed some anterior synechiae and used an 10-0 proline double arm suture, STC6, and create a mattress retention suture, actually implementing the same technique that we use in phakic eyes with silicone oil tamponade in order to prevent the oil coming forward. I was planning just to use one vertical, in the vertical meridian with just one suture, with bites on the sclera 4 millimeters apart. So a few days later, he was back in surgery, and now that's how the lens is. We started with some conjunctival peritomy and applying gentle cautery on the sclera, and then 2 millimeters posterior to the limbus, 4 millimeters apart, using making partial thickness scleral grooves in order to incorporate and bury the knots at exactly 180 degrees opposite. And following that, using the 10-0 ProLink on the long needle, and again, the same technique, the docking needle. You can see how tilted the lens is. It's a one-piece acrylic lens. The needle, that's the first pass. And once the suture comes out, exactly the same is repeated 4 millimeters apart, creating this vertical mattress suture acting as a safety net. And the plan and the wish was that once the suture would be suture and tied, then this net would provide sufficient support from backwards so that the optic is more aligned and parallel to the iris plane. And as you can see, it's a quite straightforward procedure. It's a technique that we use quite often now with the docking needle. And the end result after the synechiolisis with micro scissors, once the 10-0 ProLink is tied within the scleral groove, you can see that immediately the lens becomes less tilted and is quite nicely centered now. So I left theater quite optimistic that I have done a good job, and next day, during the first post-operative day, my patient will be quite happy. So indeed, the next day, the patient was quite happy. His visual acuity improved. However, he had a quite significant amount of astigmatism, probably because it was my first case and I was too nervous with tying the sutures. The centration was excellent. Felt quite happy. However, nothing lasts for long, and the patient at the 5th month post-op came back with an anterior chamber reaction and pseudophakic cystoid macular edema. Apparently, I was quite aggressive, as I explained, with tying the knots, and as you can see in the anterior OCT, there is some touch between the nasal part of the iris and the optic, causing some iris chafing and causing the cystoid macular edema. Unfortunately, this edema became recurrent, as we will see in the future. Tried with an vitreal triamcinolone, and I can see that following this first injection, the cystoid macular edema improved. However, it came back a month later. This time he had a Nosardex injection, which gave us 8 months of normal contour and resolution with edema. Unfortunately, he developed once again cystoid macular edema, treated again with intravitreal triamcinolone, improved within a month. Recurrent cystoid macular edema in April 2019, again the third intravitreal triamcinolone, and luckily since then and almost now for 21 months, his macula remains with a nice contour and no recurrent cystoid macular edema. So does it work? Does this technique work? I had the opportunity to apply it in 6 cases within a year, and all cases were males, and the indications were traumatic cataracts in 2 of them, pseudoexfoliation, sunset syndrome in 3 of them, and an aphakic eye after a pars plana vitrectomy. The follow-up, I have seen them now, some of them for more than 3 years. And the outcome at the moment is that all of these patients have quite centered intraocular lenses and quite stable, and they have improved their visual acuity significantly. I haven't seen any significant complications apart from a very transient vitreous hemorrhage in one of them, probably related to passing the suture through the sclera. Of course, there was a case of refractory cystoid macular edema, eventually treated successfully with steroids, and the astigmatism is possible an issue post-op. That's all. Thank you very much.
Is there any question from the panel?
Συγχαρητήρια, Δημήτρη. Πολύ ωραίο περιστατικό.
Thank you, Petros.
Πράγματι, το περιστατικό είναι πάρα πολύ ωραίο. Εγώ, επειδή κάτι ανέφερε στην αρχή, είχα ένα περιστατικό με λίγο μεγάλη αιμορραγία και ουσιαστικά την έχω εγκαταλείψει αυτή τη μέθοδο και I opted περισσότερο προς Καρλεβάλε αυτή τη στιγμή. Εν πάση περιπτώσει, next speaker is Mr. Thanos Papakostas, Assistant Professor of Ophthalmology at Cornell Medical School, New York. Mr. Papakostas.
Thank you very much for the... Yes, thank you very much for the very kind invitation to speak again in the meeting. So I'm going to talk today about the management of diabetic tractional detachments. These are my financial disclosures. So I'm going to basically cover the preoperative considerations when we treat these patients, and I'm going to go into detail with a few illustrative cases in terms of the intraoperative techniques. So these patients are quite sick patients. Whatever is happening in their retinas is basically happening in their kidneys, in their hearts, in their brain, in their nerves, everywhere. So if you look at this paper, the mean survival after diagnosis of a TRD requiring vitrectomy is 2.7 years. 50% of these patients will be dead by 10 years. So these are very, very sick patients. You need to get anesthesia clearance. You need to have these patients see an anesthesiologist. You don't want to deal with surprises in the OR. You have to optimize blood pressure and glucose control. You cannot operate with uncontrolled blood pressure, with high blood pressure, because the bleeding in these cases can be devastating. And of course, set expectations for the patients. You do not want to have a patient coming back to your office in the post-op period after a successful repair and asking you, how come I'm not 20/20 after the surgery? You have to do a fluorescent angiogram or OCTA to evaluate for macular ischemia, counsel the patient appropriately in terms of the chronicity of the detachment and what's a realistic expectation after the surgery. I like to do PRP and anti-VEGF before taking these patients into the OR. The PRP, the laser, decreases vascularity, it prevents TRD progression, it decreases operative time and it reduces post-op inflammation, and the anti-VEGF is very quick in decreasing the vascularity in these fibrovascular membranes and minimizing the bleeding that we can encounter intraop. And as you already all know, this has been published extensively in the literature. I'm going to focus on this paper that they basically randomized 160 patients to two groups to receive pre-op Avastin. The first group was 1 to 3 days before, and the second group was 5 to 10 days before, and the second group did a little bit better in terms of post-op complications at the end of the follow-up, which was 6 months. And this is a characteristic example. This is a 33-year-old type 1 diabetic. Visual acuity is 2300. You can see the extensive ischemia and the big fibrovascular membrane over the nerve. The patient received Avastin, and a week later, this is how it looks when we went inside the eye. So the vascular membrane has become more like fibrous tissue. So that was very helpful in terms of the bleeding in the surgery. Visibility is king. If you cannot see, you cannot operate. I like to use Viscot to coat the cornea. It's a little bit hypertonic, so it always keeps the cornea dehydrated. You will not get corneal edema. And if you encounter corneal edema, you can use 50% dextrose. I rarely scrape corneas. I can't remember the last time I scraped a cornea on a diabetic patient. You really don't want to do it because diabetic epithelial defects, they are very hard to close. So just use Viscot, and if that's not enough, you can put a few drops of a hypertonic solution. I like to use dextrose in the bottle. Most of these patients are phakic, and I try to avoid combined phaco-PPV. It gives you more inflammation, you have synechiae, you may have poor visibility intra-op to do the fine peeling maneuvers. The IOL can be displaced by the gas, so I have the patient see the cataract surgeon. They will do the phaco, and then a few weeks later I will treat the retinal detachment. I know in Europe you guys do the phacos too, so you can do the phaco first and then do the retinal detachment, but not everything in one go. And the techniques are very well described in the literature. You have to relieve the epitraction, segment and delaminate the membranes, isolate the fibrovascular proliferation. You try to avoid creating any breaks, and if breaks happen, you have to clean any fibrous material or hyaloid around them. The new cutters that have been developed by various companies over the last few years have been amazing in basically tackling these cases. The bevel cutter gives you significant advantage because the opening of the cutter is very close to the tip of the cutter, so you can go very safely very close to the retina surface and do all these complex maneuvers. And I like to use the cutter as a multi-purpose tool. It's basically like a Swiss Army knife. You can use it as a cutter, as a pick, as a blunt dissector, as vertical scissors. Back in the day, 20, 30 years ago, you would use all kinds of scissors for these cases. Now, the cutter, most of the times, is enough, especially the 25 or the 27 gauge cutters. And I'm going to start with this case. 33-year-old type 1 diabetic. You can see the fluorescein, the color picture on the OCT. This is extreme PDR. I use the ingenuity on almost all my cases, and especially for these tough diabetics, because the visualization you get is so much better than the conventional scope. So first I start with the release of the epitraction, and then I tackle the posterior membranes. I usually go from the nerve outside, but here I basically go depending on the anatomy. So it's easier to get a plane from outside towards the nerve, so that's how I do it. I use the 25 gauge bevel cutter to basically segment the membranes. As you can see, the visualization is great with the ingenuity. You can see all the planes nicely. So I go with the cutter almost touching down, and that's the advantage with the beveled cutters. This is a high-speed cutter too, so there's minimal motion of the underlying retina when you're doing all these maneuvers. As you can see, slowly these membranes are segmented, delaminated, and isolated. Here I remove the FVP over the nerve, and then I continue with the delamination. You can see here how tight the spaces are and how nicely the cutter can go into these tight spaces and release the membranes from the retina. I use conformal and fold back delamination as it has been described by Steve Charles in the past. And then I like to stain with triamcinolone to highlight any residual vitreous, and I proceed with the shaving of the periphery under scleral depression, laser, and I put a short-term tamponade in this eye. And this is how the eye looks 1 year later. The vision is 20/30. We have a very good PRP. The patient didn't need anything else. And this is how the OCT looks. This is a more complex case. It's a 57-year-old woman with type 2 diabetes. Vision is hand motion. We have a combined tractional rhigmatogenous retinal detachment, and where the yellow arrow is, it basically shows the micro breaks in the retina, and this is how the OCT looks. So again, I'm using the 25 gauge beveled high-speed cutter. We know it's a combined TRD RRD because there's presence of subretinal blood, as you can see inferiorly, and the cutter is a very nice tool to segment all these bridges and delaminate the membranes. Here there was a plane already. There was like a partial separation of the hyaloid and the macula, so that was quite helpful in order to find the plane and proceed with the case. Here I'm using my light pipe to release the hyaloid, and I'm draining the subretinal hemorrhagic fluid through the break inferotemporally, and then the rest is pretty much standard with laser and C3F8. So this is how the patient looks. That's a year later. She got cataract surgery and her vision has improved to 20/25. And for the ones that really like the 23 gauge systems because, they're more efficient, they've been used with these systems, for many years, you can use them, and then you can use a hybrid approach. You can use a 23 or a 25 gauge setup, and then when things get tight, you can put in the 27 gauge cutter. And that gives you an extra advantage of tackling even harder membranes because the 27 gauge cutter has a very small opening and you can go into the tightest spaces. That's a more complex case. This is a 33-year-old type 1 diabetic, vision is hand motion. You can see pretty bad fibrovascular proliferation. This is how the OCT looks. And here I'm following a hybrid approach, 25/27, with the bevel cutters. You can see the extensive membranes here. It's very tough to get a plane. That's why I went with a 27 gauge cutter. And once I get a plane there, I proceed. Again, really tough membranes, long-standing retinal detachment. Of course, this patient has been counseled pre-op that, we can get anatomic success, but perhaps the vision might not be that great after the surgery, but you can definitely stabilize the eye. Look how tough these membranes are. But the 27 gauge cutter does the job slowly but surely. I'm using the pick to get off the membrane from the inferior arcade, and then I remove a subretinal membrane. And this is something that I rarely do. I did a focal posterior retinectomy because the membranes were so embedded into the retina that the retina wouldn't just relax with any peeling maneuver. So when you are stuck in these cases, it's better to do a small focal retinectomy and clean everything around so that you get the retina down. And this is how the patient looks 6 months later. Vision is count fingers. Anatomically, it looks very good. Functionally, we'll take it. The eye has been stabilized. The eye will never be lost. The eye will not go to NVG or other, bad complications. And this is a 36-year-old man, type 1 diabetic. Vision is 2200. He had extensive PRP in the past, but he progressed to a tractional retinal detachment involving the macula. And here again, a hybrid approach, 25/27. And You will see why, because the spaces are so tight. We can do essentially dissection over the fovea with a 27 gauge cutter. You can see that I'm basically getting the hyaloid over the fovea with a 27 gauge cutter. That's something that we couldn't do in the past with the larger instruments, but now with these small cutters, all these maneuvers are much safer. See that we're working through a cataract here, and the view with the Ingenuity and the flat lens is actually very good through a cataract. So here I'm proceeding with the segmentation and the delamination. It's a tedious process. Here the membranes are extremely tight, so the 27 gauge cutter gives us an advantage. And the job is to basically release the traction. The job is not to remove every single membrane from the retina surface. Once you've relieved the traction, that's all you need. Again, I'm cleaning up membranes in the inferior arcade. And the rest is pretty much standard with laser and tamponade. And this is how the patient looks 3 months later. Vision is 20/50. We did not make a break. We did not drain the subretinal fluid. The fluid went away naturally. This little cuff of fluid is basically gone now. And as I said before, you do not have to remove every single membrane. These membranes superior to the optic nerve were left because they were not exerting any traction. So in terms of tamponade, you can use air or nothing if you're 100% that there's no break. I like to use gas. In oil, I'm not a fan of oil. I use it if I have to, especially in reops, but definitely not for the first surgery. It has less surface tension compared to gas, and if you get a hemorrhage under the oil, you can get pretty bad perisilicon oil proliferation. So in summary, use pre-op anti-VEGF, be meticulous but know when to stop, don't lose the case for nasal membranes, and as a very wise man has said, Gil Grant, in the past, it does not matter how the picture looks, but how the patient quote-unquote looks, and embrace new technology and instrumentation. Thank you very much for your attention.
Thanos.
Yes.
Hello, I'm Yannis Tatseris.
Oh, hi, Yanni.
Χάρηκα πολύ που σε είδα, είσαι πολύ ανεβασμένος και σου πάει πολύ ωραία το μουσι.
Είσαι ωραίο.
See you next year live here. Okay.
Okay.
You can proceed.
Thank you, Mr. Papakostas, for your presentation. I'd like to thank all the speakers for beautiful presentation and constructive discussion. Mr. Petro, I think, do you like to
συγχαρητήρια για
tell
την
something?
παρουσίαση. Συγχαρητήρια για τα χειρουργεία. Great surgery. Thank you all for being here. Hopefully next year we'll show you Athens by night. And take care. Ευχαριστούμε για όλους που παρακολουθήσατε και μην ξεχάσετε, είναι το τελευταίο session του συνεδρίου. Μην ξεχάσετε, μιλάμε στους ομιλητές, στους ακροατές, να μπείτε στο site και να δηλώσετε, γιατί υπάρχουν 20 υποτροφίες της εταιρείας Αλοειδούς Αμφιβληστροειδούς για διάφορα συνέδρια και courses του χρόνου, αλλά θα πρέπει να δηλώσετε συμμετοχή μέσω του site. Καληνύχτα σας.